All right, if we welcome back to the urinary chapter. If you guys remember, last time we left off, we were talking about the glomerulus and how it filters out solutes from the bloodstream, and how it's basically smaller and smaller pores created first with the fenestrated walls of those capillaries, those very porous walls. Um, we have the basal lamina, which is that collagen fiber meshwork that acts sort of like a colander. Uh, and then you have the podocytes with their pedicels interweaving and making the narrowest slits, preventing anything smaller, I'm sorry, or larger than 6 to 7 nanometers through. So when it comes to this filtration membrane, the fluids and solutes that exit the bloodstream and enter this capsular space, the thing that makes the biggest impact on this is the size of the pores of this membrane. You guys remember that we saw biggest pores in the fenestrations, we saw medium pores in the basal lamina, and then the smallest pores in the podocytes. And this is going to really allow glucose, electrolytes, very small proteins, and naked amino acids to leave the blood and enter the capsular space, but it prevents things like red blood cells, platelets, or any really formed cells, as well as large proteins. It keeps all of those things inside the bloodstream. Now, there is another group of compounds that leaves the bloodstream called nitrogenous wastes. These are things like urea and ammonium, and urea and ammonium are really waste products of protein metabolism. You also have creatinine, a waste product of the creatine kinase reaction that occurs in muscle cells and several other body cells. You also have uric acid, and uric acid is when nucleic acid metabolizes. This waste product is created. And so because of their small size, all of these compounds are really easily able to flow across the filtration membrane and be filtered out by the kidneys. Now, there is a percentage of plasma that passes through the filtration membrane and enters that capsular space, and this is called the filtration fraction, and it averages about 20%. So what does that mean? It means that 1/5 of the plasma that flows through the glomerulus is going to exit the blood and enter the capsular space. And this is so large because of how intensely looping the glomerulus capillaries are. And this looping really just increases their surface area, so much so that if you were to take all of the filtration surfaces of one kidney, they would be about 6 square meters. That's about the size of a small bedroom. And that's just in one kidney. And this large surface area is what makes this filtration super, super efficient. Now, filtrate is going to be formed really rapidly at about 125 milliliters per minute. This value, this amount of filtrate formed by both kidneys in 1 minute is called the glomerular filtration rate. And over the course of the day, both kidneys produce about 180 liters of filtrate. Imagine drinking 92-liter bottles of soda in one day, and that's the amount of liquid that runs through your kidneys just as filtrate. This is an impressive feat, all right, considering you only have 3 liters of plasma. So what does that mean? It means that the entirety of your blood volume is filtered 60 times a day. And the kidneys are able to do this so efficiently because the glomerular capillaries are so permeable. However, even with these fenestrated capillaries, filtration is only going to occur if there's a pressure gradient that's able to push water and solutes through a filtration membrane. Think of that Play-Doh sculpture that I showed you. There has to be pressure behind it to push things through this filter. So let's look at these two forces that drive fluid movement. The first is hydrostatic pressure, and this is the force of a fluid on the walls of its container. So in this case, in these blood capillaries, blood pressure is typically the ability to push water out of the capillary and into the interstitial space, right? So the other one is called colloid osmotic pressure, COP. And this pressure is created by essentially proteins in the plasma. And so the osmotic gradient is created by these proteins that pulls water into the capillaries. So if you guys remember, water will flow from high to low, right? So in the interstitial area, there's not a lot of solute, but if there is a lot of solute in the bloodstream, in these capillaries, well, then water's going to move back in because the percentage of water is lower. This interaction of these two forces is going to create what is called the net filtration pressure, the NFP of the capillary bed. And this determines the overall direction of water movement between the capillaries and the interstitial fluid. Um, so hydrostatic pressure is going to push things out of the capillaries if it's higher, and COP, colloid osmotic pressure, is going to pull water into the capillaries if it is higher. So it's a blow essentially if it's the hydrostatic pressure, and it's a suck if it's the COP pressure. And these same situations are pretty much there in the glomerular capillaries, but there's a third, slightly more complex force to factor in, and that is the hydrostatic pressure of the fluid in the capsular space. Remember, this isn't just interstitial fluid, this is flowing into the capsule. And so this is called the glomerular hydrostatic pressure, and it's largely determined by the systemic blood pressure, but it measures considerably higher than that of a typical capillary bed. And so this is because blood leaving a capillary bed will enter a low resistance venule, whereas blood leaving the glomerulus enters a high resistance efferent arteriole. So arteries are going to be under more pressure than veins. Remember that. It's the same, like if you've ever seen a TV show where a person has an artery cut in surgery, that blood is going to spurt. And that's true. It's under higher pressure than if a vein is cut. Veins bleed, droop, bleed, but arteries spurt because they're under higher pressure. And this arteriole's high resistance is due to its smooth muscle and its small diameter. And it's going to cause this fluid to back up and push up against the walls of the glomerular capillaries. So this is going to favor movement through the filtration membrane. This is going to favor pushing things out into the capsular space. Now, glomerular colloid osmotic pressure, GCOP, is going to be just like the COP in typical capillaries. This is going to be created by, proteins like albumin in the plasma. And this averages about 30 millimeters of mercury of pressure, and it is slightly higher than normal capillary bed pressure, but that's because the blood in the glomerulus tends to be a little bit more concentrated because water is rapidly going to leave through the filtration membrane. And so that causes any solutes left in the blood to increase in concentration. And so the higher the blood solute concentration, the higher its osmotic pressure. So the GCOP is going to oppose filtration, drawing water into the capillaries via osmosis. These work the exact same way, right? They're just a little bit higher pressured. Now, you also have capsular hydrostatic pressure. So think of this like emptying a kitchen sink with the faucet turned on. The fluid in the capsular space is draining into the renal tubule as fast as it can, but it's a set rate. This rapidly accumulating filtrate inside the capsular space will build up a pressure of its own called capsular hydrostatic pressure, CHP, and it's about 10 millimeters of mercury of pressure. And it's going to try to push water back into the glomerular capillaries. So the CHP and the GCOP are going to oppose filtration into the capsular space. But the highest pressure one, the GHP, glomerular hydrostatic pressure, that's going to still be higher normally, and it's going to push more fluid across. So the net filtration pressure should tend to be from glomerulus into glomerular capsule. And that we can see here. So the net filtration pressure equals the glomerular hydrostatic pressure minus the sum total of glomerular colloid osmotic pressure and the capsular hydrostatic pressure. And so the net filtration pressure is going to generally favor filtration because the glomerular hydrostatic pressure tends to be higher than the sum of forces that oppose it. There's just going to be just enough pressure to overcome those forces because of that arterial backup. So it's squeezing this fluid and these solutes out of the glomerulus into the surrounding space, despite the fact that the fluid in the glomerulus becomes more concentrated and the fluid in the capsule tries to push back in on its own. And here you can see some of that shown out. You see glomerular hydrostatic pressure pushing out, and again, this is going to be the biggest force. You have opposing filtration, the GCOP trying to push back in because there's more water on the outside than there is on the inside. So water tries to move from high to low, and CHP is going to just be the same thing essentially. Water is still trying to move from high to low. The difference here is CHP is typically due to the fact that there's a backup of capsular drainage, essentially. And that's why it is so low, because it's like the analogy of the backed up kitchen sink is really great. As you pull open that plug, it's only draining as fast as it can, as fast as gravity will let it. But this water is going to keep pushing in, so there's going to be a little buildup. And the overall net pressure does tend to be 10 millimeters of mercury outside of the outside of the glomerulus into the capsule. So that filtration does tend to occur. Now, which of these is the best summarized statement for hydrostatic pressure? It is the force of a fluid on the walls of its container. Remember, this is that GHP that we're talking about, especially for the glomerulus. So this is the pressure that this fluid is pushing out on these capillary walls. And this is what's resulting in that plasma and other things being diffused across. Now, GCOP is best described as what? GCOP is best described as what or doing what? GCOP, remember, pulls fluid from the capsular area into the capillaries. Remember it. So pulls may not actually be the best term. Pushes would be a better term. And that's simply because water is trying to move from high to low. So water is pushing itself back into the capillaries to try to even out those pressures. NFP at the glomerulus tends to be what of these? What of these is the most accurate of NFP? NFP is typically about 10 millimeters of mercury. So that is the closest thing there. Now, glomerular hydrostatic pressure is what of these? So which one is glomerular hydrostatic pressure? Which way does it push or pull water in the glomerulus? First is the first thing you need to know. So GHP, remember, GHP is the one that pushes plasma out of the capillaries into the capsular space. So this is going to be increased by that high resistance arteriole. That high pressure arteriole is smaller than the glomerular blood vessels, and so it sort of backs up and it increases that pressure. And so just like the Play-Doh spaghetti hair, it's going to squeeze out. It's going to squeeze all this fluid out through those pores. And I do want to say that, the overall pressure tends to be, since it tends to be about 10 millimeters of mercury, this relatively high pressure combined with those leaky glomerular capillaries and their huge surface area yields that average of 125 milliliters per minute. So if we look at this, comparing the glomerular filtration rate to the rate at which systemic capillary beds lose water, okay, which is about 1.5 milliliters of water per minute. So in the glomerulus, you lose 125 milliliters of water per minute, and in regular body capillaries, you lose 1.5 milliliters of water per minute. You'll see that's a huge, huge difference. Now, clinical A&P, let's talk about glomerulonephritis. And this is a common condition that will damage or destroy the glomeruli, okay? And this can result in inflammation of those glomerular capillaries and the filtration membrane. Now, I want you guys to remember the major hallmarks of inflammation are increased blood flow and increased capillary permeability. So with those together, this causes that filtration membrane to become excessively leaky. And you can lose red blood cells and proteins to the urine. And so if nephrons are further damaged or destroyed by this inflammation, the GFR decreases, and this triggers compensatory mechanisms that work to make up the difference in order to maintain that GFR. So this is going to make an additional loss of cells and proteins to urine. Eventually, however, these mechanisms are not going to be able to restore the GFR, and so toxic substances will actually accumulate in the blood. And this can lead to complete and total renal failure, where the GFR is not able to allow the kidneys to do their job. This is very, very dangerous. This is just the loss of blood and protein into that filtrate, and it cannot be recovered. Now let's talk about some factors that affect the GFR, that glomerular filtration rate. And glomerular filtration is essentially going to be considered the gatekeeper of renal physiology, because this is where the process of waste removal begins. And GFR is going to determine how rapidly blood is cleansed, how effectively the kidneys carry out tubular reabsorption and tubular secretion, how well the kidneys are able to maintain their homeostatic balances. And so anything that affects GFR is going to influence the overall function of the kidney. And there are several mechanisms that affect this. There are internal mechanisms called autoregulation, so the kidney regulating itself, and these have to do with maintaining the GFR that for any factors that may arise within the kidney itself. There are also external factors like neural and hormonal factors that are sort of parts of broader systems maintaining systemic blood pressure and thereby affecting GFR to do so. So we'll talk about these in this section. Now, the GHP is mostly the result of systemic blood pressure, so any change in blood pressure would alter the GHP and the GFR. That would be the logical case, but it's not really the case in real life. The GFR seems to remain relatively consistent over wide ranges of blood pressure, and this is because of their autoregulation. Autoregulation is basically these local responses initiated and maintained by the kidneys. There are two basic negative feedback loops, the myogenic mechanism and the tubuloglomerular feedback. The first one we'll talk about is the myogenic mechanism. And these basically respond to increases or decreases in blood pressure by controlling the stretching of the smooth muscle in these blood vessels. So let's say an increase in systemic blood pressure is going to stretch the afferent arteriole, and that is going to lead to an increase in the glomerular filtration rate. And so this is going to cause muscle cells to contract, thereby constricting the arteriole. So constriction of this afferent arteriole is going to decrease blood flow through the glomerulus. This is going to turn down the faucet. Think of this like a garden hose, uh, and one of your little brothers standing in the middle of this garden hose, and they put a kink in it. They're shrinking that hose, and so this is going to decrease the amount of fluid getting into the glomerulus, thereby lowering the pressure. And really the opposite is true. If blood pressure in the body decreases, this is going to cause the afferent arteriole, the one that goes into the glomerulus, remember? This is going to cause it to be less stretched and more relaxed, and it's going to dilate. And so this dilation is going to allow more blood to flow into the glomerulus, and it's going to increase GHP, glomerular hydrostatic pressure. So the example of your little brother with the hose, this is when your mother comes over and smacks him in the head for kinking the hose and ruining her flowers. And so this is what's going to just allow that pressure to return back up to normal. And this really occurs very rapidly. It restores normal filtration rate within seconds of any significant change in blood pressure. This is limited really only between 80 and 180 millimeters of mercury. And the normal range here is between 100 and 120 for systolic. And if the systolic blood pressure goes higher than 180 millimeters of mercury, this afferent arteriole can't constrict enough to restore normal GFR. Similarly, the opposite is true. If systolic drops below 80, the afferent arteriole is unable to dilate enough to restore normal GFR. So as long as systolic blood pressure is between 80 and 180, the kidneys can keep up. Now you also have tubuloglomerular feedback, and this is going to involve that juxtaglomerular apparatus that I talked about in the first section. The JGA. This system is named for the fact that the macula densa of the distal renal tubule, remember, is part of this negative feedback system that controls pressure in the glomerulus. And the basic feedback loop is this. As the GFR increases, the volume of filtrate going through the renal tubule increases as well. That makes sense, right? More plasma exits into the capsular space, making more filtrate. More filtrate is going to move through the tubules. So this increase in filtrate volume is going to lead to an increased delivery of sodium and chloride ions into that macula densa cells, okay? And so this is going to cause them to absorb more of these cells from the filtrate. So as the macula densa absorbs more sodium and more chloride, it's going to release ATP into the interstitial fluid. Eventually, some of this ATP is going to be converted into adenosine, and this adenosine is going to lead to the constriction of the afferent arteriole, the one that feeds the glomerulus. And so once this adenosine has constricted the afferent arteriole, less blood is going to flow in, right? And so that means GFR is going to lower. So there's going to be less plasma exiting into the capsular space, which means less filtrate, which means less sodium and chloride coming up and touching the JGA or the macula densa, which means less ATP is getting released. So it's just that feedback loop controlling how much ATP is released by the macula densa. Now, if the macula densa is getting more and more sodium and chloride over the course of more than a few minutes, it's going to signal those juxtaglomerular cells of the afferent arteriole, and it's going to cause them to release or reduce their release of the enzyme renin. And so renin's this overall effect here is to increase GFR and promote urine formation. So this is going to allow that juxtaglomerular apparatus to maintain a crucial role in maintaining fluid and sodium ion homeostasis. Now, there are also hormonal effects that may play on the GFR. Like two of the autoregulatory mechanisms, hormones affect the GFR by adjusting hydrostatic pressure. However, hormones that affect the GFR as part of a larger system that works to regulate systemic blood pressure, like angiotensin 2, which is a major component of the renin angiotensin aldosterone system, the RAAS. And you also have another set of hormones that regulate, consisting of the natriuretic peptides. You remember hearing about these when I talked about ANP being released by the heart. First, let's look at the RAAS. And the renin-angiotensin-aldosterone system is going to be a complex system with the primary function of maintaining blood pressure. And it preserves the GFR basically as a secondary effect. And so, for this reason, it acts on much more than just the afferent or efferent arterioles. It also significantly impacts tubular resorption and the collecting system in order to influence electrolyte balance and blood volume. And so, in addition to these, it also causes various changes throughout the body as a whole. And this system can be triggered into action by three conditions. One, stimulation from neurons of the sympathetic nervous system, the fight or flight system. Two, low blood pressure can trigger this. Or three, stimulation from the macula densa cells in response to low sodium and low chloride ion concentration in the filtrate. And it's important to note that this system can be turned on by a combination of these factors. So it's not just one, or it's not always just one. It's normally one or more. And so the RAAS is going to proceed in several steps. First, let's say systemic blood pressure drops, causing a decrease in the filtration rate. The juxtaglomerular cells are going to release renin. And this is supposed to convert angiotensinogen into angiotensin 1. And this is just going to happen as renin circulates in the body until it encounters that inactive protein produced by the liver. And so renin is just going to catalyze the conversion from angiotensinogen into angiotensin 1. And angiotensin 1 has minimal activity. So it goes from inactive to low activity. Now, angiotensin 1 is going to circulate through the blood until it encounters another enzyme called ACE, angiotensin converting enzyme. And this is going to be created by the endothelial cells like the ones in the lungs. And ACE converts angiotensin 1 in its less active form into its fully active form, angiotensin 2. If anybody likes Dragon Ball, this is sort of like the cell process. You need multiple enzymes to convert imperfect cell, into perfect cell. Now, angiotensin 2 has different simultaneous effects that influence both systemic blood pressure and the GFR on its own, including promotion of vasoconstriction of the efferent arteriole. Okay, so it's going to vasoconstrict the blood vessel that leaves the glomerulus, backing up that pressure. Now, this actually occurs because angiotensin 2 constricts all renal blood vessels, but the efferent arteriole tends to be 10 to 100 times stronger on this receiving this effect. And so this is going to clog the drain, increasing GHP. This increased pressure maintains GFR at a normal rate despite the reduced blood flow. Now, another effect is angiotensin II is going to constrict normal blood vessels. It's a vasoconstrictor across the board, and it causes effects more than 40 times stronger than norepinephrine, the other vasoconstrictor we talked about. And this vasoconstriction is going to increase peripheral resistance. And so as peripheral resistance is increased, it's going to increase systemic blood pressure. It's going to promote the resorption of sodium and chloride ions from the proximal tubule and water as it follows. One of the most powerful effects of angiotensin II is this effect. In the proximal tubule, angiotensin II promotes the reabsorption of both sodium and chloride ions out of the filtrate. And so this is going to cause water also to come across via osmosis. This is going to increase blood volume, increasing the blood pressure. And it also promotes aldosterone release, leading to increased sodium ion and water reabsorption. So angiotensin II is going to stimulate the adrenal glands to release aldosterone. And we've already covered aldosterone in the endocrine chapter, but it acts on the distal tubule and parts of the collecting system. And as filtrate passes through those, they're going to reabsorb sodium ions and water follows through osmosis, increasing blood volume and increasing blood pressure. The last effect angiotensin II does is it's going to stimulate the thirst center of the hypothalamus, increasing fluid intake, which increases blood volume. All of these increase the systemic blood pressure, and by such, they're going to increase the glomerular filtration rate. And this is what we see here. This is this sort of on top, you see the conversion from angiotensinogen released by the liver. It encounters some renin, becomes angiotensin 1. Angiotensin 1 gets converted in the bloodstream as it encounters ACE, angiotensin converting enzyme, into the active form angiotensin 2, or A2, or Ang2, I'm sorry. And all of those are going to have those effects that I just talked about. They're going to constrict the efferent arteriole, promoting filtration. I'm sorry. They're going to constrict systemic blood vessels. They're going to pull water and sodium out of the proximal tubule. They're going to pull water and sodium out of the distal tubule and the collecting system because of aldosterone. And they're going to stimulate the hypothalamus and its thirst center. So it's going to make you drink more water, it's going to increase your blood volume, and it's going to raise blood pressure. All of that in an effort to get glomerular filtration back up. Now, which of these does not increase renin release? Parasympathetic stimulation. Remember, sympathetic stimulation increases renin release. Ang2 is converted into angiotensin. I'm sorry, Ang1 is converted into Ang2 via ACE, which is located primarily in which organ's capillaries? It's produced by these capillaries, and it's located mainly in the same organ's capillaries. They're the lungs. The lungs produce ACE, and so thereby most Ang1 is converted into Ang2 in the lungs. Angiotensin II does not. So which of these is not a function of angiotensin II? It does not promote vasodilation of efferent arterioles. Remember, angiotensin II is a pretty universal vasoconstrictor. Aldosterone, which of these is an effect of aldosterone? Aldosterone leads to increased sodium and water reabsorption. Remember, all of that is in the distal and the distal tubule, and it mostly acts on sodium. Water just happens to come with it through osmosis. ACE, ACE, does what? It converts angiotensin 1 into angiotensin 2. And renin, remember, renin converts angiotensinogen into angiotensin 1. All right, so you guys remember we talked about ANP in the endocrine chapter being released by the heart, right? And this is in response to atrial blood volume increasing. And so what this does is it works to lower blood volume and blood pressure, thereby lowering the workload of the heart. And so this is going to essentially accomplish this task by dilating all the afferent arterioles and constricting efferent arterioles of the glomerulus. And in combination, this combination basically turns up the faucet and clogs the drain at the same time. So this is going to massively increase glomerular hydrostatic pressure, raising filtration rates. A GFR that's this high is going to lead to a lot more fluid loss, and that's going to lower blood volume and effectively lower blood pressure. Do note that ANP is a part of a system that works to decrease systemic blood pressure. This GFR effect is simply happenstance. Now, I said there's also neural regulation of the GFR, and it's mostly mediated by the sympathetic division of the ANS. And as with hormonal symptoms, the sympathetic nervous system, the SNS, affects the GFR mainly in a larger effort to control blood pressure. Sympathetic neurons releasing norepinephrine during times of increased sympathetic activity causes systemic blood vessel constriction. That includes the afferent arterioles, and so it elevates systemic blood pressure. You would think this decreases GHP and the GFR, but the sympathetic effect on the GFR isn't quite that simple. Instead, it has an overall effect depending on how much it is stimulated. If the level of sympathetic stimulation is low, let's say you're mildly exercising, or you're walking or jogging, sympathetic neurons are going to trigger those juxtaglomerular cells to release renin. The renin leads to the low-level formation of angiotensin 2, which in turn raises systemic blood pressure, maintaining GFR. This, if you think about it, this makes sense. Your body has no need to decrease the GFR if you're going for a jog or if you're nervous about a test. Now, if there's a lot of sympathetic stimulation, there's going to be a large amount of renin that is secreted, and this blood concentration of angiotensin 2 is going to increase dramatically. And so this huge amount of angiotensin 2 is going to widely constrict arterioles, including the afferent and efferent arterioles, decreasing GFR. This is especially important in cases of severely low blood pressure and dehydration. This is going to help the body minimize fluid loss and preserve blood volume and blood pressure. In these cases, like perfusion of vital organs like the brain or the heart is going to take precedence over filtration of the kidneys. Your body knows that you need to hold on to this liquid or you're going to die. And so it's going to prevent as much fluid from being lost as it can. All right, so let's look at this as a sort of concept boost. Up here on the top, we have vasoconstriction, and on the bottom, we have vasodilation. Okay, and how do each of these affect glomerular filtration rates? All right, so if the afferent arteriole is constricted, okay, so that means that the blood flowing in to the glomerulus is lowered. There is a lower amount of blood flowing in. The hydrostatic pressure is lowered, and therefore GFR is lowered, right? Now, on the opposite hand, if the efferent arteriole is constricted, then that means blood backs up. It fills up these capillaries more easily squeezing out any plasma or solutes, right? So that means GHP goes up and GFR overall goes up. So again, think of it like a hose. Think of it like a hose. If you constrict the amount of water going into your hose, there's not enough water trickling out the end to make a forceful spray. However, if you uh, if you take your finger and put it over the end of the hose, you're going to notice that lots of that pressure in the hose builds up behind you, and so you're going to find that it swells, and so there's more pressure behind you. Um, so this is the example of your little brother. This one here is the example of your little brother, like 50 feet behind you, kinking the hose, giving you giving you low pressure. This one over here is you putting your finger over the hose and getting your own pressure back up. Now, on the other hand, you have vasodilation, and this is just a little different. In the afferent arteriole, okay, the one that feeds the glomerulus, if it is dilated, that means more blood flow is entering the glomerulus, right? And so that means that if the efferent arteriole is unaffected, then there's going to be more pressure. This is going to be an example of turning up the faucet while the gravity of the drain is only doing so much, right? So overall, an increase in filtration rate. Now, the opposite is true if you dilate the efferent arteriole. If you open up the arteriole that drains this glomerulus, it's the equivalent of saying, okay, let's leave the faucet turned on, but instead, let's just get a larger diameter pipe that drains it. So this would allow more water to flow out. In this case, it'd be more blood. More blood flows out of the glomerulus more easily, lowering that pressure and lowering GFR overall. And this is really going to be, this might be tricky for some of you guys, so please don't hesitate to email and ask if you have a question about how any of these constrictions or dilations affect blood flow, because this concept will be on the test. And here you can see the summary of all these controls between hormones and autoregulation and neural mechanisms. And I've already gone over these, but feel free to just look at this, pause this image, look at it, study it if you need to. But I'm going to be moving on now. Now, let's say a person's filtration rate lowers enough. They'll enter into what is called renal failure. This is just a condition where the kidneys are unable to carry out their vital functions. And there's a huge number of conditions that lead to renal failure, like anything that decreases blood flow to the kidneys, kidney diseases themselves, or anything that obstructs urine outflow. Short-term renal failure, called acute renal failure or acute kidney injury, is common actually among hospitalized patients and typically resolves with treatment of the underlying cause. But some people develop chronic renal failure, and this is long-term renal failure, and this is defined as a decrease in the GFR lasting for longer than 3 months. And this can be seen with patients that have diabetes mellitus or hypertension, high blood pressure. And the symptoms depend on the severity of the renal failure. With mild renal failure, you might not notice any symptoms, but as renal function declines, patients will experience fatigue, edema, nausea, loss of appetite, and then eventually they'll get to severe renal failure, where the GFR is less than 50% of normal, and so a condition here called uremia will occur. And uremia is the buildup of waste products and fluid and electrolyte and acid-base imbalances. Untreated, a uremic patient can enter a coma, can have seizures, or even die. And when a patient develops these signs and symptoms of uremia, dialysis treatment is the first thing people run to. And there are two types of dialysis. There's hemodialysis and peritoneal dialysis. And so the first is hemodialysis, which temporarily removes a person's blood, passes it through a filter that removes metabolic waste and extra fluid, and also normalizes electrolyte and acid-base balances. And hemodialysis is typically performed 3 times a week at a dialysis clinic. The second type is peritoneal dialysis, and for this one, fluid is placed into the peritoneal cavity, allowed to circulate for several hours, and then it's drained. A patient typically undergoes peritoneal dialysis every night at home, and so this, for many patients, is the long-term preferred treatment. Now, there are 3 classes of drugs that act on the RAAS to reduce blood pressure. And basically, all these drugs work to lower blood pressure. First, you have ACE inhibitors. This class of drugs that's actually developed from snake venom blocks angiotensin converting enzyme and therefore inhibits the conversion of angiotensin 1 into angiotensin 2. You also have ARBs, angiotensin receptor blockers, and they block angiotensin receptors on blood vessel cells as well as the proximal tubule. And so this prevents vasoconstriction and sodium ion water reabsorption, respectively. You also have aldosterone antagonists, which block the effects of aldosterone on the distal tubule, therefore lowering the amount of resorption of water, sodium, and ions. Or sodium ions and water. God, that was weird. As a side effect, ACE inhibitors and ARBs block the effects of angiotensin 2 on the kidney. And so that means it does not constrict the efferent arteriole as it normally would when the RAS is activated. This opens up the drain, okay, decreasing the hydrostatic pressure, and so therefore reducing the filtration rate. And typically this can have a surprising effect on certain types of renal disease. Diabetes mellitus and hypertension damage those glomerular capillaries, which in turn lead to renal disease and a decrease in the GFR. And you might think that treatment goal in these cases would be to increase GHP in order to increase the GFR. But think about this. What would happen if you put more pressure on an already damaged glomerular capillary? It's only going to shred it and damage it even more. This is where those ACE inhibitors and ARBs come in. Lowering the GHP, they're able to decrease the pressure exerted on the glomerulus, right? And so although this does tend to lower GFR, it also lowers glomerular capillaries' chances of sustaining further damage, prolonging the life of the kidney and preventing that patient from entering renal failure.
So as we've talked about, filtrate formation, the rate of filtrate formation is really, really high. And so the kidneys actually have to work very hard to reclaim most of that filtrate and return it back to the bloodstream. If you guys remember, this is tubular reabsorption, and this is in the nephrons and the collecting system. Of about the 180 liters that's filtered out, only 1.8 liters, 1%, actually gets turned into urine and leaves the body. So that means that we're reclaiming about 99% of the water that gets filtered out. And so given the magnitude of these quantities, it's not going to be surprising to learn that kidneys use about 1/5 of the body's ATP at rest. And so since we reabsorb so much of this water in the first place, you may be wondering why we need to filter the blood through the kidneys at all. And so the first thing is certain waste products are not reabsorbed. In addition, despite this high GFR, some waste substances do not immediately pass through the filtration membranes in the glomerulus. And so this necessitates tubular secretion, which is the opposite direction that tubular reabsorption occurs. these non-reabsorbed and secreted substances are typically toxic when they're present in high concentrations. And so this high GFR and the process of secretion ensures that as much of it is cleared out of the body as quickly as it can be. In addition, the presence of a large amount of filtrate in the nephrons gives the kidneys really fine-tuned control over these fluid, electrolyte, and acid-base balances. If the body doesn't need these substances, they're simply excreted. If they are needed, they'll be reabsorbed back into the blood. And so we're going to look at all this, these processes of reabsorption and secretion more closely, and we're also going to trace the filtrate as it passes through the nephron and the collecting system.
So let's look exactly at how and where these substances are moved. In tubular reabsorption, substances have to pass from the filtrate in the lumen of the tubule across or between tubular cells into the interstitial fluid, and finally across or between the endothelial cells of the peritubular capillaries to be reabsorbed. So in secretion, the substances are going to move in the opposite direction. But how do they accomplish this goal? So there are two different routes across epithelial. There's paracellular and transcellular. And so just as a quick review, paracellular route is when the substances pass between adjacent tubule cells. And so these tight junctions between the tubular cells are just leaky enough to allow some substances like small ions and water to move passively through them. And this especially happens in the proximal tubule. And this paracellular route is typically passive, and it requires no energy, no ATP, because it really consists of water moving by osmosis or solutes moving in their concentration gradients. And if we're talking about the transcellular route, substances like glucose and amino acids have to be transported across tubular membranes. And so a reabsorbed substance first crosses the apical membrane of the tubular cell. So this is going to be the one facing the lumen. And then it travels through the cytosol and exits the cell through a basolateral membrane. And this is going to be the side facing that interstitial fluid. And this typically does not require ATP, typically does not require ATP, but some substances that are moved along transcellularly do require ATP since they go against their concentration gradients. And so this is either directly or indirectly requiring that ATP energy. And secretion is going to be an active process, so it actually has to occur via the transcellular route across the tubular cell membrane. Oops, there's the transcellular slide that I forgot to move forward to. It's the same thing. It has to diffuse across both membranes into the interstitial fluid. So here you can see some of that reabsorption taking place. On top up here, you see some paracellular paracellular reabsorption, and it's going in between these two lumen cells, these tubular cells. And so you see this area here is going to be the lumen of this tubule, represented here as well. So solutes, water and ions are going to pass in between those tight junctions of these two cells, and they're just going to go into the interstitial fluid and eventually back into the peritubular capillary. Now, you also have that transcellular route where solutes like glucose or other macromolecules have to be transported across the membranes. And so that's going to require, a carrier here and a carrier here. So that could potentially be passive diffusion requiring no energy, but it's more likely that it's going to require some ATP in the form of this active transport. And again, secretion is going to be the opposite, typically an active process,
as this toxin or whatever is pulled out of the blood and transported through a basolateral membrane, through an apical membrane, into the lumen of the tubule. And you can see that this is the proximal tubule here in the nephron. Now, most of these solutes that are going to be reabsorbed or secreted transcellularly have that ATP use, right? So they need a carrier protein that will diffuse them across the membrane. And so if you guys remember, there are three ways that carrier proteins are used. There's facilitated diffusion, which does not use any ATP. This uses a carrier protein that passively transports a solute with its concentration gradient. So it goes from high to low. You also have primary active transport, in which a carrier protein pump directly uses ATP to move a solute against its concentration gradient. In this case, there are antiport pumps and symport pumps. Antiport pumps move two or more solutes in opposite directions, and symport pumps move two or more solutes in the same direction. Both really have a limited number of sites on which they can transport solutes. So it might help you to think of these as a train only having a certain number of seats for passengers. And once all their sites become filled, the carrier proteins are said to be saturated, and they have reached their transport maximum. Any solutes unable to bind to these carrier proteins likely will not be transported and will end up in the urine. This is what happens in diabetes mellitus, as we'll talk about in a little bit. Now, you also have secondary active transport, which uses a concentration gradient set up by a primary active pump, and that gradient is used to drive the transport of a second solute against its concentration gradient through the use of another carrier protein. Now, the TM, the transport maximum, becomes really important with substances like glucose that fill seats really rapidly. And this fills these seats in these proximal tubular cells very, very rapidly. And if too much glucose is in the filtrate, the transport maximum is going to be reached before all the glucose can be reabsorbed. And so there will be glucose in the urine. This is a condition called glycosuria. And glycosuria is commonly seen in the diabetes mellitus patients, and this is characterized by a defect in the production of or the response to the pancreatic hormone insulin. And so insulin is what causes most of those cells to take in glucose, right? Without this insulin, these cells are unable to bring excess glucose into their cytosol, and this can lead to a high level of circulating blood glucose or hyperglycemia, high blood sugar, and this can result in excessive amounts of glucose in the filtrate and eventually ultimately into the urine. Now let's look at the filtrate as it goes from the capsular space through the nephron and collecting system, right? We're going to start at the proximal tubule. If you guys remember, the proximal tubule has lots of microvilli, providing these cells with large surface areas, right? And this facilitates the remarkably rapid absorption, or reabsorption rather, that occurs in this very active segment of the renal tubule. In fact, the proximal tubule is where about 6% of the ATP in the body gets spent, even at rest. Most of the filtrate is reabsorbed here. In addition, all of this reabsorption, there's a great deal of secretion that takes place here as well. And so we're going to look at the changes that this filtrate undergoes in the proximal tubule. And most activity is going to take place without any outside control. There are some exceptions, like parathyroid hormone decreasing phosphate ion reabsorption.
In addition, the sodium-potassium pumps in the basolateral membrane can become more active in the presence of angiotensin II, and this can explain how this hormone increases sodium ion reabsorption from these cells. But the main roles of the proximal tubule in reabsorption are as follows. First is the large percentage of electrolytes like sodium, chloride, potassium, sulfate, and phosphate ions. All of these electrolytes are vital for electrolyte homeostasis. And it turns out this process is really key to reabsorbing many of the other substances in this proximal tubule. Much of the sodium ion reabsorption occurs transcellularly through sodium ion leak channels. Another mechanism for this transcellular sodium ion reabsorption involves 3 types of carrier proteins. There are carrier proteins specific for sodium ions that enable facilitated diffusion. There are sodium ion symporters that bring sodium ions from the filtrate into the cells with other solutes like glucose. And then there are sodium hydrogen antiporters that will bring sodium ions into the cells while secreting hydrogen ions back into the filtrate. And it turns out that most of both the leak channels and these carrier proteins rely on a concentration gradient created by sodium-potassium pumps in the basolateral membrane. These pumps are continuously driving sodium out of the tubular cells into the interstitial fluid, creating a relatively low sodium ion concentration in the tubular cell. This sodium ion concentration is significantly higher in the filtrate, and so that steep concentration gradient is critical for all of that secondary active transport of the many other solutes. Now, in the first half of the proximal tubule, you're also going to find those sodium-glucose symporters. Okay, and these symporters use this sodium ion gradient created by the sodium-potassium pumps to carry both glucose and sodium ions out of the filtrate and into the tubular cell. This is an example of that secondary active transport. Once these solutes are in the cell, this glucose is going to be transported through facilitated diffusion into the interstitial fluid, where it diffuses back into the peritubular capillaries. There are other symporters in the apical membrane of the proximal tubular cells that function in a similar manner, allowing this secondary active transport of sodium ions and another solute like sulfate ions or phosphate ions, or an organic solute like amino acids or lactic acid. So all of these occur because of this sodium gradient that is created by the sodium-potassium pumps in that basolateral membrane. And so this is how that glucose reabsorption is going to work. And it all starts with this sodium-potassium pump down here in the basolateral membrane. It's going to push sodium out of the cell into the interstitial fluid and pulls potassium in. This creates a low sodium region, low sodium concentration inside that cytosol of the tubular cell. The sodium glucose cotransporter, this sodium glucose symporter at the apical membrane, is going to move sodium in to reset this balance, and it's also going to pull glucose in at the same time. This is that secondary transport that I've been talking about. Eventually, this glucose is going to make its way down to a carrier protein in the basolateral membrane, and it's just going to facilitate a diffusion its way right on out, just through the concentration gradient from high to low. And it's going to diffuse across the interstitial fluid into the peritubular capillary. So you can see all that there at the bottom. So the basic path is, let's choose green. So sodium is going to move out here, which means sodium moves in here. But when sodium moves in from here, it also pulls this glucose in with it.
And so this glucose builds up until it becomes higher in here than it is out here. And so glucose just facilitated diffusions right on out. And then again, it's going to go from high to low. So it's going to diffuse straight across into this capillary. And it all begins with this sodium-potassium pump creating a low sodium gradient in there and a high sodium gradient in here. Listen, I'm writing with a mouse, okay? It's not going to look very neat. But as long as you guys can keep that straight, I think you'll be okay on this. Now, as sodium ions are going to be reabsorbed, things like anions, like chlorides, are going to be absorbed additionally as well. As sodium ions are passively transported out of the tubule lumen, this lumen is going to generate a net negative charge. And so this creates an electrical gradient that pushes negatively charged chloride ions across the epithelium paracellularly. These chloride ions follow very similarly to the sodium ions into the interstitial fluid and eventually back into the plasma as well. Now we also have bicarbonate ion reabsorption, and this is going to basically be very, very similar to the carbonic acid bicarbonate buffer system that you guys should have covered in A&P 1. If you guys remember, carbon dioxide in the blood is going to react with water and produce carbonic acid. This reaction is catalyzed by an enzyme, carbonic anhydrase. And this newly formed carbonic acid will spontaneously dissociate into bicarbonate and hydrogen ions. And this complete reaction is shown here. If you guys remember, carbonic anhydrase also catalyzes the reverse reaction, turning carbonic acid into carbon dioxide and water. And this bicarbonate reabsorption in the proximal tubule occurs in a really roundabout way. Sort of like a game of fetch. The cell is going to toss hydrogen ions into the filtrate, and the hydrogen ion fetches a bicarbonate ion, which is then brought back to the cell. This toss is accomplished via those sodium-hydrogen antiporters that we've discussed. This carrier protein transports sodium ions into the cell and throws hydrogen ions into the filtrate. So the whole process is broken down like this. Hydrogen ions are secreted from the cytosol of these tubular cells into the filtrate. This hydrogen ion will react with bicarbonate ions to form carbonic acid. This carbonic acid is going to be converted by carbonic anhydrase to reform carbon dioxide and water. And this is done via the carbonic anhydrase found on the apical plasma membrane of the tubular cell. So these newly formed carbon dioxide and waters are going to diffuse into the tubular cell cytosol, and they're going to combine with water there to become bicarbonate and hydrogen ions. And so this within the cell, this carbonic anhydrase that has brought these things together is now going to break them up again. It's going to dissociate them back into bicarbonate ions and hydrogen ions. Eventually, these bicarbonate ions are going to be transported across the basolateral membrane into the interstitial fluid and eventually diffusing into the peritubular capillaries. This whole process is basically going to repeat as hydrogen ions are again secreted back into the filtrate. Any hydrogen ions that are released when carbonic acid dissociates these two are going to be recycled. And so again, the sodium hydrogen antiporters are just going to bring more sodium in and kick more hydrogen out. And so through this mechanism, it allows these cells to resorb about 90% of all bicarbonate ions from the filtrate. And so this is what allows the body to maintain a very precise pH of the blood between 7.35 and 7.45. We should see that process here. So as you can see, this whole process is going to start here with this sodium hydrogen antiporter. As it pulls sodium in and pushes hydrogen out, this hydrogen that gets pushed out is going to combine with some free-floating bicarbonate ions, and it forms carbonic acid. So this carbonic acid is going to be converted on the apical membrane of these tubular cells into water and CO2, carbon dioxide. This water and this CO2 are going to be transported into the cytosol of the tubular cell, and once it gets in there, more carbonic anhydrase is going to turn it, it's going to convert it back into bicarbonate and hydrogen ions. You see some more bicarbonate here, and this hydrogen is the side product, sorry. So once this bicarbonate is created, it's going to diffuse across, you see this bicarbonate has been created here, it's going to actually diffuse across the interstitial fluid back into the bloodstream, while this hydrogen that's been created is going to be kicked back out and start the whole process all over again. Now, by the time the filtrate has reached the second half of the proximal tubule, most of the sodium ions, as well as glucose and other organic compounds, have been reabsorbed. The accumulation of these solutes in the cytosol will draw water out of the filtrate by osmosis along both paracellular and transcellular routes. If you guys remember, osmosis, water moves to the solution with a higher solute concentration. So a higher solute concentration, but a lower water concentration. So water is still moving high to low. And this is actually called obligatory water resorption because the water is, quote unquote, obliged to follow solute movement. And so a kind of water channel in the plasma membrane here called aquaporins greatly enhance rapid water reabsorption. If you guys remember, we talked about aquaporins when we talked about antidiuretic hormone. These aquaporins are located in both the apical and the basolateral membranes of these proximal tubular cells, and they allow water to move quickly across these cells transcellularly. As this obligatory water reabsorption continues, the concentration of solutes like potassium, calcium, magnesium ions is going to continue going up in the filtrate. This creates a concentration gradient that's going to favor their diffusion into or between the proximal tubular cells. If you guys notice in this process that active reabsorption of solutes is going to stimulate further reabsorption of water by osmosis. And as water continues going up, it's going to stimulate more passive reabsorption. So it's sort of a feedback loop. As more gets absorbed, more gets absorbed, more gets absorbed, more gets absorbed. It sort of just follows that logic. And in this photo here, we're looking at the obligatory water reabsorption in the proximal tubule. So the first thing you see are solutes passively diffusing or are actively transported into the tubular cell, right? And so as the solute concentration in the cell goes up, water is going to be pulled in through the aquaporins, and you can see those there, aquaporins moving water in via osmosis, moving from low solute concentration to high solute concentration, otherwise known as moving from high water concentration to low water concentration. And again, you can see that this also occurs paracellularly. Now, the same thing is going to basically happen as solutes are transported via facilitated diffusion or active diffusion into the interstitial fluid and eventually into the capillaries. These aquaporins are still going to be carrying water along with them from a high concentration to low concentration of water or low concentration of solutes to high concentration of solutes. Now, as I discussed earlier, there is hydrogen ion secretion, but there are other substances that are secreted into the filtrate by these proximal tubular cells, like nitrogenous waste products and drugs. In the first half of the proximal tubule, most of the uric acid in the filtrate is reabsorbed, but nearly all of it is secreted back into the filtrate in the second half of the tubule. Additionally, you're going to find ammonium ions. There's like creatinine and small amounts of urea that are also secreted. And then drugs like penicillin and morphine have significant renal secretion. And these drugs have to be taken often, about 3 to 5 times a day, because that medicine is so quickly lost through renal secretion that it has to be replaced in order to maintain relatively consistent blood levels. Now, if we look at this, which of these is the correct pathway for fluid filtrate as it becomes urine? Which of these is the correct pathway of filtrate? It starts at the glomerulus, and then that filtrate gets secreted out into the surrounding capsule, right? The glomerular capsule. Then it gets pushed into the proximal tubule, pushed down the nephron loop, into the distal tubule, and eventually into the collecting duct. Remember that pathway. Glomerulus, proximal tubule, nephron loop, distal tubule, collecting duct. And the proximal tubule is going to do which of these? Which of these is it going to do? Which of these is the most accurate to which it does? It reabsorbs about 90% of those filtered bicarbonate ions. So remember that's one of the biggest things that this proximal tubule does. It does a significant amount of resorption, but it resorbs about 90% of these filtered bicarb ions. Now, once filtrate actually hits the nephron loop, it barely resembles the original filtrate. 60 to 70% of the electrolytes in water are gone back into the blood, and most organic solutes like glucose and amino acids are gone. As the filtrate flows through this nephron loop, it undergoes even more losses. 20% of the total water, 25% of the total sodium and chloride ions, and a significant portion of any other remaining ions are reabsorbed and returned to the blood. In the proximal tubule, you're going to see that the water reabsorption is proportional to the solute reabsorption, right? More solutes absorbed, more water absorbed. For this reason, the filtrate in the proximal tubule has the same osmolarity as the interstitial fluid. But in the nephron loop, the filtrate's osmolarity is going to change as it flows through here. And so this is due to that differing permeability in the ascending and descending limbs of the nephron loop. And this thin descending limb is really freely permeable to water, but less so to like ion solutes. So water is really easily able to move out of the thin descending cells via osmosis, but few solutes actually follow. This causes the osmolarity of the filtrate to go up as it passes down the descending limb, rounding the bend of the loop, right? Now, the cells of the thick ascending limb are going to be impermeable to water, but very readily transport sodium chloride into the tubular cells through sodium potassium chloride symporters. This secondary active transport brings in 1 sodium, 1 potassium, and 2 chloride ions into the tubular cell, relying on sodium-potassium pumps still in the basolateral membrane. So as those basolateral pumps push sodium out, these symporters pull sodium in, but they also manage to pull in potassium and chloride. And if you guys remember, this is also going to push potassium cells back into the tubule, so there isn't much net reabsorption of potassium in this process. Now, as the filtrate is going to pass through this ascending limb, it generally loses solutes and becomes gradually less and less concentrated as ions are going to be pumped back into the interstitial fluid.
In juxtamedullary nephrons, the differing permeabilities in the two limbs and the changing concentration of the filtrate are generally part of a larger system that allows for extensive water reabsorption from the filtrate in both the loop and the collecting system. Now the filtrate has entered the first part of the distal tubule. About 85% of the water is gone and 90% of the sodium ions have been reabsorbed. So filtrate flow rate is really, really low. It's about 20 milliliters per minute rather than the original 120 milliliters per minute. So as you guys saw when we talked about this earlier, these cells of the distal tubule lack any significant microvilli. And so most water reabsorption has already taken place. And the cells do not require that much surface area to reabsorb most of the water. However, reabsorption is still critical. If we excreted all this water that was still left, we'd lose about 29 liters of water a day and a significant portion of our sodium ions, not compatible with human life. So this early distal tubule is really structurally and functionally similar to the ascending limb of the nephron loop, right? But the latter portion of the distal tubule is very similar to what is called the cortical collecting duct. So we're going to talk about them together. Now, the primary cellular type of the late distal tubule and the cortical collecting duct is called a principal cell. And these principal cells have hormone receptors that determine their function. And so the majority of their activity is regulated by hormones that work to fine-tune water, electrolyte, and acid-base balance. So any absorption that occurs here is called facultative water reabsorption because water here is reabsorbed in accordance with the body's needs. Facultative just means the ability to adapt to a need. And these hormones are going to be talked about here, as well as water and electrolyte balance. And so they are aldosterone. We've already talked about aldosterone as a steroid hormone made and released by the adrenal cortex. It's going to interact with the DNA of cells and increase their permeability to sodium ions and to increase the number of their sodium-potassium pumps. Both actions are going to work to up the amount of sodium ion reabsorption, and so they also up the secretion of potassium ions into the filtrate. You guys note these waters also indirectly cause more water reabsorption as well as more chloride absorption, because as sodium ions are reabsorbed, water and chloride ions passively follow. Aldosterone is also going to stimulate the secretion of hydrogen ions into the filtrate via another type of cell called intercalated cells. And these intercalated cells are going to be found in the late distal tubule and the cortical collecting duct. And we've already talked about antidiuretic hormone made by the hypothalamus and released from the posterior pituitary gland, right? Do note that diuresis in this case is going to refer to losing body water to urine. And so a diuretic is an agent that promotes diuresis. An antidiuretic is an agent that causes water retention, reducing water output, or reducing urine output, rather. And so antidiuretic hormone is going to exert its effects by causing aquaporins to be inserted into the apical membranes of principal cells, permitting rapid water reabsorption. And so in the presence of antidiuretic hormone, principal cells are barely, in the absence of antidiuretic hormone, principal cells are barely permeable to water, and a larger volume of water is lost in the urine. Makes sense. No antidiuretic hormone, nor aquaporins, water stays in the urine, or in the filtrate rather. You also have atrial natriuretic peptide, and we've talked about this as well. It stimulates natriuresis, or urinary excretion of sodium ions. And so this appears to also inhibit the release of ADH and aldosterone, causing fewer sodium ions and thereby less water to be reabsorbed, and so more sodium ions and more water appear in the urine. Now, we've also got the medullary collecting system, and as filtrate flows through it and the papillary ducts, this is the last chance of the kidney to regulate fluid balance or any homeostatic balance before this filtrate officially becomes urine. And so the principal cells of the medullary collecting system have several properties. They are impermeable to water in the absence of ADH. However, with ADH present, they're able to reabsorb large amounts of water. They are permeable to urea, which allows some urea to move down its concentration gradient back into the interstitial fluid. And these principal cells can continue to reabsorb ions like sodium chloride and bicarbonate from the filtrate. In addition to this, both the principal cells and the intercalated cells in this region both actively secrete hydrogen ions from the interstitial fluid into the filtrate against a very high concentration gradient. They can increase this concentration of hydrogen ions in the filtrate by about 900 times. And we're actually going to revisit this a little bit as part of a mechanism that allows the kidneys to concentrate urine and conserve water. Now, the distal tubule and the collecting duct are best summarized as what? They reabsorb the majority of the remaining water. Remember that. Now, the kidneys are able to adjust reabsorption and secretion, and this helps maintain pH homeostasis, especially when we're talking about hydrogen and bicarbonate ions. Now, thus far, we've seen two examples of acid-base regulation in both the renal tubule and the collecting system. The cells of the proximal tubule secreting hydrogen as a way to reabsorb bicarbonate, and the principal and intercalated cells of the late distal tubule and the collecting system actively secreting hydrogen ions. Now, there is another mechanism, and in the renal tubule cells, if stimulated, when the pH of the blood becomes abnormal, if it becomes too low, too acidic, enzymes in the tubule cells will remove an amino group from the amino acid glutamine in the cytosol. Okay, and what this does is it generates two ammonia molecules and two bicarbonate ions. And what this does then is the ammonia is secreted and the bicarbonate ions are reabsorbed. In the filtrate, you're going to see the ammonia molecules bind and buffer hydrogen ions, forming the ammonium ion. This in the filtrate, yeah, you see they become ammonium ions. Both ammonia buffering and bicarbonate ion reabsorption help to raise the pH of the blood back to normal. On the other hand, if the blood pH increases, making it too alkaline, the tubule cells will instead just refuse to absorb bicarbonate ions from the filtrate. Instead, they will excrete them into the urine, lowering the pH of the blood. And so as I leave you looking at this photo, you're going to remember that tubular reabsorption and secretion are going to be vital processes that handle enormous quantities of water and solutes, allowing them to cross their cells every day. Filtrate entering the proximal tubule is going to contain water, ions, and organic solutes, right? And then by the time this filtrate leaves papillary ducts and becomes urine, most of the water and solutes have been reclaimed. As you look at this photo, you see the summary of these substances that are filtered, reabsorbed, and secreted by the nephrons and the collecting system of the kidneys. And so I'll just give you a couple seconds to look at this. But that is it for this one.
I will see you guys in chapter 24, part 3.